C to CHC. No,
That's awesome.
I
Awesome.
can't wait to see you in person, Irene. It'll be great.
Yeah, I
And
cannot
I,
wait for the Mai Tai.
yeah, exactly. It is winter here in Chicago, and I am sick. You know, you got to love that. So I can't wait for spring, and I can't wait for better weather.
The weather here in Miami is not so great either. It's rainy, it's humid, but it's cold. It's like very confused. Really, really confused.
What's the temperature like in Miami right now?
60, I want to say, like 66,
Yeah,
67.
it's been chilly. It's been nice.
Uh-huh. It's been chilly for a while now, which is nice. A nice change.
All righty, we'll go ahead and kick it off. Good afternoon, good morning to those joining. Thank you for joining our February QTECH committee call. We're happy to have you. We have lots of great updates, lots of great guest speakers. As always, we do have the chat open, so if you have any questions throughout the meeting, please feel free to drop them in the chat, or if you'd like to raise your hand, and we will call on you. The session, as always, is recorded, so we will send it out to you and your teams to review if you have someone on your team who was unable to join. And as always, thank you for joining. We really appreciate your participation and engagement in this forum. So without further ado, we're happy to bring you the latest updates for February, which is American Heart Month, and our latest CVD updates. So we have our beloved Stephanie Smith, our manager of clinical quality here. She's going to be giving us some updates on American Heart Month. We have Michelle Fundora, our community engagement manager. She's going to be giving us updates and ways to get involved in our latest Alzheimer's and Dementia Care ECHO program. Lots of great information there. And we will be closing out the meeting with Dawn Bell. We'll be doing part 2 of our social determinants of health. Epic possibilities are endless. We're happy to welcome Dawn Bell back as part of the second part of our series. And then lastly, we'll close out with some upcoming activities and opportunities for clinical engagement and opportunities for you to join us in person if you can. So I will hand it over to Stephanie Smith for American Heart Month and CVD updates.
Thank you so much, Natalie. And good afternoon, everyone. I'm covering the updates as Antoinette is out of office. I'm really happy to present some of the things that her and our clinical quality team have led on for American Heart Month. As you all know, February is American Heart Month. And in honor of this, we wanted to highlight some of the updates and activities that have been going on within this past month with you all. So if we go to the next slide. Here we're taking a look at Wear Red Day. So February 2nd really kicks off American Heart Month as Wear Red Day. The purpose of this day is actually to spread awareness on the importance of maintaining a healthy heart. Heart disease is the leading cause of death in this country and has actually been since 1950. And so this is just an opportunity for us to show our commitment to you all and supporting your efforts to improve heart health outcomes for your patients. And so we're happy to present on this slide some examples of our health center teams that are representing for Wear Red Day. And so here we have BCOM, Jesse Trice, and Evra. So we really appreciate you all sharing in your photos for Wear Red Day and just highlighting your opportunity to recognize that awareness day. We go to the next slide. Here we're taking a look at some of the clips from our newsletters. Newsletters are another opportunity that we're getting out information to you all from the network in terms of our efforts to engage in CVD efforts. And so here we're just highlighting Million Hearts, specifically that program to prevent 1 million heart attacks and strokes. We are very thankful to partner with BCOM, Evra, and Jesse Trice on this initiative and participating with us. And so on this slide, what you can see are some of the breakthrough activities that they initiated during the project period. So a common trend across the board, of course, is focusing on provider education and motivation to help exceed some of those improvement metrics. I really appreciate the ways that they've been able to engage their clinical staff in these different initiatives, whether it's recognition programs where I know that BCOM has a trophy, a Heart Champions trophy that really helps in that competition. Another call out with their efforts is also in reference to mindfulness and meditation, thinking about how this impacts of stress impact the way that their clinical teams can take care of their patients. So that's a really interesting spin. Another thing to highlight is also that EVRA is looking at the statin noncompliance, so doing massive chart reviews to figure out what exactly is going on with those patients who have not initiated statin therapy. And using those chart audits is an opportunity to help either engage the patients as well as informing providers, just so that they understand in their clinical teams kind of what the process is. How can they identify some of those trends and opportunities to enhance their statin therapy performance? And Jesse Trice as well has been promoting provider education and also getting information out to providers about the statin therapy guidance and making sure that their clinical teams are educated on what the guidance says for prescriptions of statins and helping to do incentives for monetary bonuses as another example of how they're trying to engage clinical teams in efforts such as these. And so one of the things we're trying to do within the newsletters this year is we have segments where it calls out take a beat. And it's an opportunity to just ask the question, at least in reference to this one, what are ways that your health centers are motivating and educating your providers and support staff in these efforts? We go to the next slide. Here we're taking a look at another spotlight opportunity. And so with this one, what we're looking at is another initiative that is available through the American Heart Association, which is Change Control, which is referencing their efforts to help manage cholesterol management here. So we're highlighting and we're excited to highlight Orange Blossom Family Health as a health center that was recognized in that initiative for their quality improvement efforts in partnership with the American Heart Association. And so here's just a snapshot of their interview. So we were able to ask them questions about their program, how engagement with that resource helped to improve their quality performance, and what kind of resources were available through that engagement. So a lot of cultural competency related materials to help ensure that their patients understand truly what the impacts of cholesterol are. As you all know, cholesterol and heart-related disease efforts, a lot of times patients may say, well, sure, my cholesterol's high, but I don't really feel anything, or I don't think that there's anything for me to focus on. And so education truly is a big part of getting that understanding out so that you can engage your patients in that way. So great work, Orange Blossom, on this. If we go to the next slide, here we're taking a look at PDSA cycles. And so that's another highlight we wanted to provide in the newsletters just so that everyone is on the same page about taking a moment through American Heart Month just to reassess some of your workflows. And when you think about cardiovascular disease. So examples of PDSAs to think about through American Heart Month could have been looking at your staff compliance with taking that secondary blood pressure. Is that indeed happening throughout the flow of your practice? Or thinking about even at what point in the flow for a patient are they getting their blood pressure taken as another opportunity? Is it maybe at the very beginning and it could be very high stress and lead to that elevated reading? So just assessing kind of what the flow looks like from a patient's perspective can also help to do a PDSA on that. We also have a quote that's available here on the screen, and it's one we promote often because we really treasure what Dr. Torres shared about this, which is treat hypertension with the same urgency as an infectious disease. As we all mentioned, right? Sometimes the symptoms are not as apparent, but showing that sense of urgency with patients helps to get them also engaged and understand the importance of treating their hypertension and also cholesterol as something that they should be concerned about in their health and journey to improve their health. We go to the next slide. Taking a look at this slide for partnerships. Partnerships are truly critical when it comes to our ability to help enhance the support that we provide all of you in terms of the space of CVD health efforts. We were really excited last year to host an opportunity with the American Heart Association, where we had a heart equity symposium that took place in September of last year, which is actually World Heart Day. And so in that opportunity, we were able to create a video that highlighted the event and some of the partnership and innovative opportunities that we had to discuss from a cultural competency lens. What are ways to, again, improve access to the care for cardiovascular disease health efforts? How can we get information to patients that resonates with them so that they're also engaged in this as well? We're excited to see other partnership opportunities. This was a local event, but we're still in the process of exploring other chances to make this even broader nationally to get even more resources available to you all. If we go to the next slide. Thank you. So taking a look at this, we are actually participating, Health Choice Network will be participating in the American Heart Association Heart Walk. Specifically, this is one where we have local staff that are going to be able to participate in person. But we're just highlighting this here for any sort of local health centers that want to participate. We have a QR code that's able for you to either register for that event and participate under the HCN Family of Health Centers team that's going to be participating at this Broward Heart Walk. We also have opportunities to also donate if you're not able to attend in person, but we're really excited about this opportunity just to showcase our involvement in the Heart Walk. And so if you will be there, you might see me too. Antoinette and I for sure will be there with a lot of different members of our clinical quality team to help represent. Here's another opportunity that's available. So here we have a few different thermometers, so infrared thermometers that are available through our partnership with the American Heart Association. So they were able to donate a few of those to Health Choice Network. So we do have those available if your health center is interested in receiving those thermometers free of cost. Just know that we'll have to contact you through the request form and gather that information, and we'll reach out to you. There could be some shipping involved, so that's just another thing to keep in mind. Here we're highlighting our EPIC clinical content updates that again tie back to our efforts for cardiovascular disease. And so here we're just highlighting the hypertension express lane. This was something that was recently presented by Dr. Collazo at the Clinical Advisory Council meeting. So we're really excited about this opportunity to highlight how we can streamline the evaluation and treatment of hypertensive patients and help account for those evidence-based guidelines in the process. So it includes a lot of presets for diagnosis information, medication information, labs, and more. And we already went into production on the 19th, but we're really excited to highlight this opportunity and how we're focusing on this for our health centers to remain engaged from an evidence-based practice perspective. We go to the next slide. Here we're taking a look at the cardiovascular health work group. Here we're just highlighting that the next meeting will be taking place on the 28th, so just next week. There will be an American Heart Association presentation about the blood pressure measurement policy and procedure template that is available, and also an outpaced CVD program opportunity. So if you would like more information about the event, we're happy to reach out to you so that you can have the invite to the next cardiovascular health work group. But it's really a nice opportunity to engage with health centers, not only at Health Choice Network, but as well as Alliance Chicago, just to talk about different CVD related topics. Perfect. So if you have any other future questions, feel free to contact directly with Antoinette Anwar, who is our subject matter expert on all things related to cardiovascular disease, or our clinical quality team, and we're happy to get you connected. Thank you so much. I'll pause to see if there's any questions. I'm looking at the chat. I do see that there's interest in the thermometer, so we will be sharing that form with you as well, and with the entire committee.
Great. Thank you, Stephanie. If anyone else has any other questions or comments as we proceed through the meeting, please feel free to place them in the chat. On the screen, you have Antoinette Anwar's contact information. She's our cardiovascular expert extraordinaire. So please feel free to reach out to her if you're interested in our cardiovascular work groups or any of the other resources provided earlier on. So we'll go ahead and transition to Michelle. She'll be giving us the latest updates on Alzheimer's and Dementia Care ECHO program.
Thank you, Natalie. Good afternoon, everyone. Just a little introduction of myself. My name is Michelle Pandora. I lead community engagement efforts for HCN. And I've been with the network for 19 years, so almost 19 years. Actually, I'm 3 months shy of 19 years. So it's a pleasure to be with you today, and obviously having the opportunity to share this amazing program with you, and hopefully engaging you and gaining some interest for the program. So I'm not sure if you guys know, but there is a diabetes echo program that HCN has been a part of now for, my goodness, I think over 6 years, if I'm not mistaken. It's something that we're still engaging with. The clinical quality department actually leads that program. So we are so happy that we're able to bring something similar. The ECHO program is a wonderful model of collaboration for medical education with primary care physicians and specialists that are in the field. ECHO stands for Extension for Community Healthcare Outcomes. And it is a peer mentoring program that gives you access to multidisciplinary specialists while providing guidance on complex cases. This would obviously be all centered around Alzheimer's and dementia care. The Alzheimer's dementia care program also is session-based. So there are 12 to 15 practices, practices being sessions. So you would be meeting every Thursday lunchtime, so 12 to 1 or 1 to 2, depending on the time zone you're in. And it gives you that time to obviously virtually connect with these specialists and these other providers, where you can share and collaborate how to treat complex cases when it comes to Alzheimer's and dementia. It is designed for providers like you, primary care physicians. It is not designed for neurologists or geriatricians. So this program is specifically designed and catered to be able to give you this education and collaborative model where you can share within obviously like-minded providers like you, where you can share information and ways to best practices, ways to treat cases, how to communicate with family members. As you know, Alzheimer's dementia is not just a disease that impacts the individual, it impacts the entire family. So it is one of the areas where this disease specifically helps you collaborate and helps you share what you know with and be able to treat not just the patient, but also the family. Next slide. So obviously the benefits are it expands this knowledge, has a greater reach to provide this education to providers that are in rural areas, urban areas, and they're able to then obviously treat these complex cases. It improves the patient experience, of course, decrease wait times and travel to seek specialty care, because you are basically gaining knowledge from those that are specialists in dementia and Alzheimer's. So you're able to treat the patients with this knowledge that you're gaining from having this collaborative information in this collaborative effort. Provides workforce training to the providers, improves obviously quality, safety, and population health, and reduces healthcare costs. The features are you would be using like a Zoom platform. It is virtual, so it's convenient. You don't have to drive anywhere. You can gain the information straight from your office. It is case-based discussion, so it's real life examples of these complex cases that are shared. And then you can get up to 12 hours of CMEs at no cost. Next slide. So this is what the sample of the primary care practices, which is the sessions. So obviously I'm not going to go through all of them, but you have a little bit of everything, even advanced care planning. So speaking from the heart, my mother passed away from dementia 3 years ago, this February. And if I would have known what I know now, it would have been life-changing. The amount of research and work I had to do to be able to educate my family and how we should treat, obviously, my mother and what would be the best case scenario for her in her life. So I feel as someone that went through it, having this information, having the primary care physician know all of this information would have been life-changing for me and my family. Next slide. So if you're interested in participating, which I hope you are, the QR code is on the screen. It will lead you to a forms where you can complete the information, and then we will be in contact. The program does start in April. It is 12 to 15 sessions, so 12 to 15 weeks. At this time, they're only offering the program this year. Not to say that it will not be available next year, but it has not yet been scheduled, and I obviously have not received any additional information. So I really hope that we have some providers that want to participate. It is open to anyone that is patient facing. So ARMP, APRNs, DOs, MDs. And, you know, I hope that you can participate and take advantage of this wonderful benefit that has been brought to you by the Alzheimer's Association. Thank you so much, and hope to be in contact. Thank you, team.
Thank you, Michelle. Do we have any questions for Michelle regarding this program? Again, you have the QR code to scan. If you're interested, we will be sending out the slides as well with additional resources. And you're always more than welcome to reach out to Michelle as well if you have any additional questions.
Thank you.
And thank you, Michelle, for sharing your story, your experience.
Thank you.
Alrighty, so we will transition to our part 2 of our Epic Possibilities Are Endless. We have Dawn Bell, who will be leading the effort today, along with Karen Iverson. We'll be going over the Prepare tool in Epic, as well as some additional resources relating to social determinants of health. So I will hand it over to Karen, and she will hand it off to Dawn.
Great. Thanks so much, Natalie. And thank you so much to Stephanie and to Michelle for both presenting. We are here for part 2. Our Epic Possibilities Are Endless. And there's always time for a dad joke here or there. So roll your eyes there when we say that. But it's part 2 of the Social Determinant of Health session. By the end of this session, it is our anticipation that you'll be able to understand the purpose of the Prepare form, locate and use it as Dawn demonstrates it, and then know the location and the utility and usefulness of the SDOH program guide. We did some introductions on this in our January meeting, so we're really happy to bring it forward in our February meeting. So if we go to the next slide here, I did have one very quick questionnaire. I'm going to place it in the chat now. I just want to take 1 minute, if we can, if you just click on the link on the right-hand side. This will help Dawn and me determine where everybody is. So I'll give it just a second here. See some folks filling it out. Thank you. Give it just 1 minute. And the purpose behind this is to see where we have come from the January session. Have we, do we have more folks on board with some of our questions here? So I want to give it just a moment. Thanks for your responses. Wonderful. I see them coming in, and no right or wrong answer. We just want to know where everybody is. Great. We'll give it another 30 seconds. Great. And I see a question from Care Resource. We are not on Epic. Would you still want us to answer on this form? Yes, Priscilla, go ahead and feel free to answer for us. That would be great. It does not matter that you are not on Epic. That's okay. Will help us gauge where everyone is. All right. Thanks, Natalie. We'll go ahead and go to the next slide here. So just a recap, and we introduced this last month. What is Prepare? And that long acronym stands for the Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. This is a standardized tool that is used nationally that engage patients in addressing and assessing their social determinants of health or their social drivers of health. It is evidence-based. It is standardized across LOINC, SNOMED codes, and ICD-10. It is available in our EPIC instance, and it's available in other EHRs as well. So Care Resource also has access to the prepare form. And the core question domains are the following: personal characteristics, family and home, money and resources, and social and emotional health. Those are the core domains. So I'm going to go to the next slide here. And with that, I would like to ask Dawn Bell to take it away. She's from our Healthy Planet team, and she'll be leading us through the next part of the discussion. Thanks, Dawn.
Hi, thanks, Karen. Good afternoon. I'm Dawn Bell. I'm part of the Healthy Planet team, and we are responsible for configuring all of your population health related needs in EPIC, which includes in part social determinants of health screening tools. And so I will be going into more depth on what we have configured in EPIC for you today. If we could jump to the next slide. We went through the next few slides in some amount of depth on our last meeting. So I'm going to go through these rather quickly just as a means of reintroducing the topic, and then I'll spend most of my time on some demo in EPIC. So what we're looking at on this slide is the display of the screening outcomes that we see in EPIC. We often refer to the SDOH wheel. This is what we mean when we talk about the wheel. And each slice of the wheel represents a different domain of risk that's being assessed for social determinants. The version that we're looking at here is the adult version, and specifically a pregnant or postpartum patient. I can see the postpartum domain there. We also have specific domains configured for infant populations, child populations, and adolescent populations as well. So you'll notice that the domains change somewhat based on the patient's age and also whether the patient is pregnant or postpartum. But the functionality of the wheel is the same across the board. And I will be demoing that shortly, so we'll go into good depth on that. If we could jump to the next slide. HCN has chosen the prepare as our preferred screening method for social determinants. And so the prepare and the questions in the prepare are mapped to those domains in the wheel that we just looked at. But not every question in the prepare, well, I should say not every domain in the wheel is addressed by a question in the prepare. And so this grid is available in the Social Determinants of Health Reference Guide, which is also available to you within EPIC, but it just details which specific questions in the prepare address each domain and which additional screeners are available for screening the domains that are not covered by the prepare. So there's a combination of screenings that we'll be seeing in the demo that we'll do shortly. On the next slide, this is just recapping where the prepare exists in EPIC. So providers and clinical support staff will most often access the prepare through the screenings tab for a scheduled visit in EPIC. Care coordinators and others that fill a similar job role in EPIC that are doing patient outreach could find the prepare on the assessments tab in the patient outreach encounter workspace. And patients also receive the prepare, a patient questionnaire version of the prepare through MyChart. Any patients that are MyChart active can submit their own questions to the prepare, and those will populate the wheel just as if clinical staff or outreach staff had populated the answers on their behalf. So lots of different ways that the information can get into the system. And on the next slide, it is time for us to jump into some demo. So I'm going to turn my video off and hope that my Teams doesn't crash like it did last time. One moment. And share my screen.
Perfect. And we still have you, so that's great.
Okay, good. Going to give it a minute and start talking and make sure that I'm still with you and haven't lost you all. But you have my cell, Karen, in case of any technical
I
emergencies.
do.
Okay.
Plan B. We have our cell, but we're good to go. We can see your screen.
Okay, wonderful. Thanks. So for today's demo, I'm logged in as a care coordinator. And for the purposes of this demo, I am looking at tomorrow's schedule for my department. And I'm going to review the patients who are on the schedule to see what social determinants data is already in the system for them, when they were screened last, and perform outreach to gather some of the data so that the patients have already been screened, if I can reach them, before they come in for their visit tomorrow. I will also be logging in as clinical staff. I'll log in as a nurse so you can see what the data looks like on the other side in the actual clinic visit. So for the first patient, when I select a patient on the schedule and select the plan of care report, the plan of care snapshot report here, that's the quickest and easiest way to get to the social determinants of health wheel from the schedule. Most job roles, I can't think of a role that doesn't have access to this plan of care report. If you are in Epic and you believe you do not have access and would like access, that would be a simple service request. We would be happy to add that for you, but I'm expecting that you will see this in your view. And I can see that for this example, this patient is a brand new patient. There is no social determinants of health data that's been collected for this patient yet. So I am going to launch a patient outreach encounter in preparation for tomorrow's visit to try to collect some of this data. Okay. On the Assessments tab in the Patient Outreach workspace is where I find the Prepare. So I'll go straight there. And the Prepare is here right in line with all of the other standard assessments that the care coordinator might use. I'll tell you that these top 3 questions, the personal characteristics questions, don't actually drive any risk scoring in the social determinants of health wheel. I encourage you to collect this data if you think that it will be of use to you, but operationally there's no requirement to collect every single piece of information in the wheel. For the purposes of the demo, I will go ahead and fill these out, but just keep in mind that they're not driving anything. They're not driving risk scoring directly. Okay. The next questions in line, everything from here onward is connected in some way to the wheel. The family and home questions pertain specifically to the financial portion of the SDOH wheel and the housing portion. So number of family members, I'll enter 3 for my patient. My patient reports they do have housing, but they are not worried about losing housing. The next section contributes also to the financial portion of the wheel. My patient reports that they have less than a high school degree. They are working part-time. They have Medicaid for their main insurance. And in the past year, they report that they had $35,000 worth of income. They tell me that they, oh, and also a transportation question as part of this section, that they have had difficulty getting to medical appointments due to lack of transportation. This whole next set of questions is linked to the financial section of the wheel, except for the food question. This one drives the food domain. My patient reports that they have not been unable to get food in the past year. They have been unable to get utilities. They have not been able to get healthcare, not been unable to get phone, not been unable to get clothing. They do not have any children in the household. And again, there's no requirement to answer all of these. The system won't stop you if you leave one out, but they are all contributing to the risk scoring in the wheel. This section on social and emotional health contributes to the stress portion of the wheel as well as the social connections portion. My patient reports that they are in contact with friends and family 3 to 5 times a week and that they feel somewhat stressed. These final questions are optional. The last 2 contribute to the IPV domain in the wheel. These 2 about jail, prison, refugee, these do not contribute to any risk scoring in the wheel. My patient reports that they have not spent any time in prison, they are not a refugee, they do feel safe, and they have not been afraid of their partner. So when I close this section, I can see the answers back in chart review, or I can see the domains that have risk assessments, chart review, snapshot, and then the plan of care report. So this is one area that the care coordinator can see those answers right away. And you can see they used to all be gray. There had been no assessments done. Now, if I hover over each one, I can see when the assessment was taken and what contributed to that risk scoring. Care
And Dawn, we do
coordinators,
have
yes.
a question in the chat, if I may. One question is, could the income question be linked to the UDS federal poverty level fields?
That's a really good question. I don't think that they can be linked. I will look into that. I will check. I'll see what we can do about that, because the ones that are in demographics need to be done for UDS. And so if you have to pick one, stick with that one, but we'll look into how we could maybe link those up. The Prepare is a standardized tool that we've copied into Epic, so it's reflecting the questions that are naturally included in that tool. It's a good question. And I see from Malama a question about Z codes. So we're working on some tools right now. We're in process with some new development that will kind of present providers with the outcome of certain screenings and will encourage them to add the corresponding Z codes as visit diagnoses. That is not yet completed. It's not yet in production, but a diagnosis code could be manually added by adding the diagnosis here. Operationally, I don't know if you would want the care coordinator doing it at this point in the process, or if it would be the provider doing it downstream, but the Z codes can be added as visit diagnoses manually at this time.
Great questions, everybody. Keep them coming. Feel free to put them in the chat, or we can pause too. Anybody want to come off mute and ask any questions? Okay.
Okay. So this is one area that care coordinators can see social determinants in their workspace. You might also notice over here in the storyboard, this is unique to care coordinators, behavioral health, I believe, and perhaps also women's health has this section in their storyboard for easy access. It is designed to show domains that are at risk, so either red or yellow, as well as domains that have not been assessed. So that's why you're seeing a different set of domains here than what we see here, because intimate partner violence, food, and housing are being left out here since they've already been assessed and have been assessed to be not at risk. But by hovering over this section, we can see all the same details that we can see in the wheel. So by completing the prepare, I've populated several of the domains in the wheel. You can see that there are still some that are left over. Depression is covered by the PHQ. The smoking and alcohol use assessments are part of the social history. And the physical activity assessment is also separate. That's not covered by the prepare. So operationally, there are some options. You might choose to have these remain part of the standard rooming process for a scheduled visit, since these are commonly handled in standard rooming workflows. You could have the care manager follow up on these while they have the patient on the phone. And to do that, as the care coordinator, I just click the single hyperlink. When I hover over a domain that I want to assess individually, I click the hyperlink and it will launch that assessment that corresponds to that domain. We get quite a few questions about the assessments that live under this header. I'll click it so you can see what's there. These are some standard Epic released SDOH screeners that are available to us. They are not the prepare. And so the question that we get a lot is, why, when I fill out this assessment, why is it not populating the wheel? So just to reiterate, we're driving use of the Prepare as the primary screening tool. These are available for use in the future and in some cases have been linked to the wheel. So currently this hunger vital sign survey and this intimate partner violence, the HARC, the 4-question HARC, those have both been linked to the wheel, but not everything in this assessment, this long assessment that you see here, not all of these are currently linked to the wheel. So just be aware that the Prepare is the preferred method, and that is the one that we're expecting to drive the risk values. Any questions, additional questions about this portion of the demonstration?
Great. I'm not seeing questions in the chat, but great information, Dawn. Thank you.
Okay. So I have completed my outreach with this patient who's coming in for tomorrow. The next patient on the schedule, I'll take a look at their plan of care report, and I can see that there has been some screening done in the past. If I hover over each domain, I can see when it was done. So for example, this patient was assessed for financial resource strain in February of this year, so rather recently. Food insecurity, not since August of 22, so quite a while back. Transportation in September of 22. So operationally, it'll be up to your center to decide how frequently you would like to reassess patients, as well as which domains are priorities for you to assess. We've looked at which domains are already covered by the Prepare if you're using that tool. Other domains, you may choose how often to assess, or you may choose to, how often do you want to repeat the Prepare for patients who are coming in more frequently. But by hovering over the assessment, you can quickly and easily see whether a reassessment may be needed. The final patient on the schedule for tomorrow, I can see that there has been some data collected here. And when I hover, I can see that that data was actually collected today. And that is because this patient submitted their Prepare through MyChart. So you can see that even though it's patient submitted data, it's populating the wheel straight away. And it's just the same as if I had performed the outreach and asked the patient these same questions today. Any additional questions on the screening process or the tools that are available in EPIC?
Dawn, if I may, I have one question for the group, and feel free to stick it in the chat or come off mute. At what roles at your health center are completing the Prepare form? What roles are asking those questions? Okay, thanks, Amanda. Carrick nurses, Malama team, medical assistants.
Great. Those folks will actually be covered in the next portion of the demonstration.
Wonderful. Commonwealth team, community health workers, case care managers, care coordinators, case managers, patient navigators. Love it. So a variety. Care coordinator. I just have one more question for the group as well. Hawaii team, patient navigators, nurse care managers, MAs do a broad SDOH assessment. Wonderful. And Zoraida, care coordinator. So that's great. Are any CHCs doing or asking questions outside of the Prepare form? Are any CHCs asking questions outside of the Prepare form? Any screening questions? Mandy, hand up. Hey, Mandy Lee.
Hey, good morning.
Hey.
So for ICHC, broadly, the MAs will do their usual rooming flow, tobacco, screeners, and they tend to hit the SDOH wheel. There are a few questions where we ask them to go to the wheel and fill up the rest of the grays, like are you able to get food? Do you have difficulty with housing? Um, and they answer those questions by clicking into the wheel and hitting those boxes. So they don't connect to the prepare. Our team of patient navigators and nurse case managers do the full prepare, but our MAs do that other flow in their general rooming workflow.
Wonderful. Thank you so much, Mandy Lee. This is great. CareArc team, we do follow up, such as using the audit tool, the PHQ-9 tool, etc. So we do perform follow-up there. That's great, CareArc. Howard, we ask additional food insecurity questions to determine food prescription eligibility. That is great. Daniel from Providence, we ask people if they need legal help. Wonderful. So it's great to see all of the different CHC roles that are involved in asking these questions. And then what are the different types of questions that you're asking? So this is great. And we hope to have more of these. Mandy Lee has a question. Where do you document within the social determinant of health wheel any additional food insecurity questions? I wonder if Dawn could answer that or Howard Rubin could answer that.
Howard, is your Food RX questionnaire many questions long, or is it a 2-question survey?
4.
Okay, so I think that there is a special standalone food security questionnaire out there. That one has
Yes.
not been linked to the wheel. That's a separate, more in-depth
Correct.
screening. There is a 2-question survey that you can get to by clicking the header of the social determinants of health wheel. This 2-question food and security screening is the hunger vital sign, and that one is linked to risk scoring in the wheel. So the 2 methods right now that connect to the wheel are the single food and security question in the prepare and the 2-question survey, the hunger vital sign that you see here. And then
Thanks.
that longer survey, Howard, is
Yep.
a separate one.
Which is the one we use, the longer one. Yep.
Mm-hmm. Okay,
Great.
should we
Thank you
move
so
on to
much, Howard.
the clinic side of the demonstration?
That'd be great. Thanks, Dawn.
Sure. So I will get back into the system as a nurse now. Okay, so now I'm going to walk through the standard rooming workflow as the nurse, no longer doing patient outreach. We will see pre-charting warnings here just because these patients are technically on the schedule for tomorrow. Pretend that it's today. Okay, and actually, you're going to get a little sneak peek here today. Our screenings section in the clinic workspace is getting an overhaul, a facelift. So you may or may not have been notified about the changes that are coming, but this is something that's in process right now. You can see the tabs across the top here for the screenings activity, but all the same screenings are still available. So the prepare in the clinic workspace is located here under the standard tools. So from the clinic perspective, I can see the wheel itself on the schedule, just the way the care coordinator could by using the plan of care report. I can also see it in chart review, just like the care coordinator. But when I'm looking at the prepare from this view, I can see how frequently, I'm not sorry, not how frequently, how recently these, the last values were taken. So this is another way, if you have staff going through the prepare as a regular part of their rooming process, they can see right here whether the last value was today or yesterday or last week or maybe a year ago to also help determine whether rescreening is needed at today's visit. And I see your hand up, Allison.
Yeah, so during one of the things we noted was that during our UDS, our migrant, farm worker, and seasonal was way much lower on the UDS. If this is screened here, will this field populate migrant or seasonal farm worker as it relates to UDS and the UDS table?
Cassie, are you still on the line? Okay, that's a no.
I am.
And
Yep.
where does that come from?
Just like the other question that was asked about the FPL, this is a separate screener. It's not a discrete EPIC field built in. So we can look at trying to tie it back to those fields, but my, gut EPIC old soul is telling me that would be a configuration challenge to get that to tie back to it, just because of the way the EPIC stores all the fields that you're doing in registration and demographics versus how we build screeners. So the difficult answer is no.
I'll ask my question in the chat. Thank you.
Yeah, we are actually having a UDS whiteboarding session with EPIC and HCN next Friday. So if you have ideas or solutions or things that you want to be better, please get them to us so that we can start opening development request tickets and we can cross-reference all the things that we need to do. I want your wish list, your gold list, your platinum list. Give me the things that if you had a magic wand or we had a magic wand, it could make it better. Send that our way, please. You can send that to Caitlin and I.
Great questions.
Wonderful. And Allison will be emailing away. One question from Kara. So those fields have to be completed in demographics then? Sounds like yes.
Correct.
Yes, ma'am.
Gotcha. Thank you.
So as the nurse, I can see that the prepare was already taken very recently for this patient, so I will not be repeating the prepare today. But if I click on the next section, this is the wheel cleverly disguised as a rectangle. It's the same data, just a different shape, and it behaves the same way as the wheel. So the gray icons here are the same as the gray slices of the wheel that we saw in our other views on the schedule and in the snapshot report. So this would be a quick way. I think it was Mandy who said that the MAs fill out the gray parts. So by clicking the hyperlinks here for the domains that have still not been assessed, it will link you to the appropriate screening areas to complete those. So for tobacco, it opens up my history activity and my patient report. She has never been a smoker and has never used smokeless tobacco. I will go ahead and complete the alcohol while I'm in here. Alcohol use is yes. Drinks per week is 1 can of beer per week. My patient has a drink 2 to 4 times a month, 1 or 2 drinks, and never has 6 or more drinks on one occasion. Okay, so now we can see that my tobacco has updated to green. My alcohol use has also updated to green. I will go ahead and complete the physical activity. My patient gets 3 days of moderate exercise for about 30 minutes each. And then we can see that that updates as well. Same thing could be done with the depression domain here. So the workflow would be to see when the prepare was last done. Are there any areas that need to be reassessed? Depending on whether the prepare needs to be redone, the nurse or the MA might choose to skip right to the social determinants section that's in this workspace and click to complete just the gray areas, just to assess the ones that haven't been done. This can also be used to reassess individual domains on whatever cadence you deem appropriate operationally. And I see Howard asked, does the depression take you straight to the PHQ-9? Yes. I should say that the PHQ-A also drives the depression domain, but that would be available where you currently access the PHQ-A. So the depression hyperlink here is the PHQ. The PHQ-A would be elsewhere. Questions about on either side, the care coordinator or the clinic staff, where they would find the social determinants tools and how they might use them.
So I have a question. This is Portia with BCom.
Hey.
I know that we're doing the tobacco screening, the PHQ-9 screening, and I know you said that operationally we should decide how frequently we want to do these screening tools. What is the best practice? What do you recommend for all these screening tools? And once we've done these screening tools, are they being pulled into the provider's notes? What's the next step once we've done them?
That's a great question. So I can speak to pulling the data into notes. There are smart links that are designed to pull the data in. So providers, they may already have templates designed that may or may not include these links. They can easily add these links or they can add them manually as needed. So if I type dot SDOH, you can see with the descriptions here that you can pull in individual domains, or there's also a link to pull in the details for all domains. If I click that one, it will pull in the details of all of the screenings and when the screenings were completed. So there's no requirement for them to pull these in, but if they choose to pull them in, either all of them together or individual, maybe just the areas that are at risk, they can choose to do that through smart links. As far as how often, I personally do not have recommendations on how often, except to say that if any of these are driving any regulatory requirements, I would certainly recommend completing those screenings related to regulatory on the required timeline, but I'd be interested in hearing what others have to say about best practice for how often to complete these.
One thing I'd like to do, Dawn, is I'll take it back to NAC as well, who was
Sure.
one of the founders of the Prepare. I know there were other partners involved, like APCHO, et cetera, to get best practices around screening dates. If they're annually or if they are below a certain level, then screen again or every 6 months, et cetera. So let's see what we can find. And I think Marcia was going to say something. Marcia Gaynor, hi.
Hey everyone. Karen, you actually kind of touched on it. I was just curious to see if there is a way, once these screenings that have been completed, the ones that are only due like annually, once it's been done, I'm wondering, is there something like, can it drop off? Or is there anything we can do so that the patient would not get it at every visit? Just hypothetically, just kind of throwing it out there and thinking of, hey, let's change the practice, but I'm just wondering, is that even possible in Epic right now?
Are you talking about on the MyChart side, which
Nope.
questionnaire the patient might receive, or just the
The
prompt to screen the patient?
prompt to screen the patient after they have already completed it. So let's say the patient was saying in January, they finished all of these social determinants of health, but let's say like tobacco screening is negative or PHQ2 or non-negative. Is it possible to do something so that they don't have to answer these questions at every single visit? Just curious. I'm just curious. Our current practice is to ask every patient every visit, but I'm just curious at other centers, is everyone doing this, or are some people kind of deactivating things once it's already done?
From a system perspective, there's no good way to, for example, exclude a domain from the wheel for a period of time. It's kind of it's showing the most recent values for each domain, regardless of when they were done. So we don't have a way to like filter down the wheel based on the last screening date. I think it's more of an operational kind of decision, how often to screen.
Okay, yeah, thank you.
And I think that's great, Dawn. One thing I'd love to encourage everybody to is let's go back to our clinical policy procedure. Let's take a look at screenings and just see what our policy currently says. And I'll write it in the chat, take back some best practice recommendations and work with NAC on that. Dawn, there is another question in the chat. Can a clinic change the order in which the screening forms appear?
Oh, on the screenings tab, I think you mean. So the order of these screenings, yes, are modifiable at the user level. So anybody has the option to use the wrench and modify the order of how those screenings appear. If I want the prepare at the top and MPOX at the bottom, I have the prerogative to move those around. Within a screening, so within the prepare or within the travel screening or any other screenings, end users do not have the ability to move those around, but the order of the screenings can be adjusted.
Dawn, thank you. And another question here. We're having issues training new users, for example, nursing and dental assistants, because everyone has edited and personalized their views and question order. Is there a way for an organization to standardize the order of questions or a view so that we can teach the system for the first 90 days and then let the staff personalize them?
Yeah, that's an interesting question. We do. So the view that a user has when they first log in the very first day in Epic is the standard. So we do, we give them a standard set. Everybody gets the same thing, but there is no lock that would prevent them for a certain period of time from customizing. So it might just be part of the training process to, encourage them to follow the standard before they start customizing.
Great. And Kara mentioning we're going to create the standard so that the most important questions are on the top and then the others are lower on the list. Great idea, Care Arc. And
It
then
would be great. Probably she's wanting the same ones that I am, because it's basically, this. It might be something that it would be good if the view could be edited, and maybe we could be on a committee, several of us that are nurses or whoever, that maybe could do that.
I think that's a great idea.
We'll take them up on it, right, Dawn?
This would be, so these tools
Allison,
are
Amanda,
used.
you've got your names.
Yeah. Cassie's recommendation is to do it as a lunch and learn, which is also good because different centers might have different orders they prefer. This overhaul that's recently been done on the screenings tab is really working to like consolidate and make it easier to find the things that you need. So after this is released and folks start using it, I expect that there will be some feedback based on that as well. Might be something good to bring to the Clinical Advisory Council, get everybody, all the centers, giving input on what's most important. Sounds great.
Dawn, something else in the chat from Hawaii. If we could talk through this question. In Energy, there was a health reminder for alcohol and drug screenings. Those don't exist in Epic. We would like to have some kind of prompt with best practice intervals applied. back on
That's a
that, Dawn?
great question. Yep. We, when we're talking about health reminders, we're talking about health maintenance in Epic. And we have focused in our oh, you're going to get a sneak peek of the new health maintenance that's coming with upgrade too. um, we have focused our health maintenance topics, which you see in the left-hand side here, on USPSTF and CDC guidelines. So if a particular reminder doesn't fall within that framework, we're encouraging use of other tools potentially in Epic. We've really reserved this for preventive care for patients that's based on USPSTF and CDC. So if there is a real need for a reminder on a particular cadence, we would have to work separately to set up some kind of alternate tool, perhaps a BPA or some other method to support that. But this is also designed as like a patient-centric preventive care thing and is not geared towards specific quality measures on a yearly basis or anything like that.
Dawn, next question. Can the screening tab be added to documentation only visits?
Let me check that. I don't know offhand. I'm just going to launch a documentation only encounter. Oh, it looks like it's already here in this view. I'm logged in as a nurse, so that could make some difference. And it could also be that the user I'm logged in as has customized their workspace using the wrench. But for the most part, if something isn't available in a workspace naturally, it can often be added from this menu. So it's possible that the screenings tab was actually pulled into this workspace manually from the more activities menu.
Great. And Carrick is saying an expert reminder annually would be great.
Mm-hmm. Yes.
We love the wish list, you all. Keep the wish list coming. We know Allison's going to be turning in her wish list, but any additional questions? These are great questions. Any questions for Dawn and the Healthy Planet team?
Yeah, I have another question. It's Portia again.
Sure.
Looking at all the screenings, are health centers expected to do all the screenings, or can we do the ones that we have programs that can impact? So if we're doing financial resource strain screening, for example, and we don't have a program in place to assist the patient, what is the utility of that screening? Or if I'm screening for housing insecurity, but I don't have any programs to assist the patient, what is the utility of that screening? Am I just doing it to say it's on file, or how is this a useful tool?
That's a really great question. There's no system requirement to use every screening, certainly. I've heard clinical leadership say that the utility of completing the prepare is that we don't know the magnitude of the problem for a population potentially until we start collecting the data. So there's a benefit in collecting the data just to kind of have the data available so that we can start getting at the root of it. But there is no requirement. And even within the prepare, you might decide operationally that if you only have programs to support certain domains, perhaps those are the ones you prioritize when you start using the tool or when you solidify your workflows.
Thank you for that. So National Patient Safety Goals 2024, one of the goals is to improve health equity for a patient. How is this tool used to ensure that we're meeting that goal, or how can it be used?
The prepare?
Yeah.
There is great information out online about the prepare. They've made everything very public. They've made their process for creating it and all of the details around using it publicly available, it might be helpful to review some of that information to see what the recommendations are in that regard. But it's a growing, thanks Stephanie for pasting that in the chat. It's an area of extreme growth right now. There's a lot going on, a lot of ideas forming around how to best meet these needs. And I think the beginning part of it is a lot about getting the data so that we know what we're actually dealing with.
Yeah, and Portia, if I may add too, I think Amanda Carrick has some really good insight into if a health center does not have an internal resource that we could refer the patient to. Carrick, for example, says we refer to an external provider or resource, but at least we would know that there is a problem. So to Dawn's point, there is tremendous benefit in even getting that baseline data to understand where are the gaps that we have today. It's really important to get our answers around certain social determinants of health, even if at this moment today we don't have a specific resource that we could send them to. I think that's the power of Epic that we will have with the tools and community resource links that we will gain in terms of linking patients to those needed resources. So I definitely don't want us to have that be a deterrent to not asking those questions. That's the first thing for sure.
I agree with that, but I'm just thinking from a patient-centeredness, when you start asking patients these questions, they expect that, there's something that you can do. If I'm asking you all these questions, then I must need this information for something. So how do you educate your patients? What do you tell your patients? Why am I asking you all these questions?
I'll open it to Amanda. I think she's got a good response there. Amanda?
Yeah, I was just going to say, just because you don't offer the service doesn't mean it's not available somewhere in your community. It could be a church outreach. It could be all kinds of different areas that you have to refer this patient to. And you're asking the question because it's important to their health, because if they're worried about a certain thing and they're not getting any assistance with it and nobody's asking the question, then they're just going to continue on with what they're currently doing. But if you're able to ask that question and say, well, we can't offer that here, but I do know a resource that we can send you to in order to, kind of help ease that transition or get you through until you can get back on your feet or those types of things. I just think it's important to know the information so that you can meet your patients where they're at. Because if you ask the question, I don't have any problem with getting food, but if you're not asking, can they have transportation? So if you don't have transportation, or if you don't have financial planners in your facility, well, there are ways that you can kind of get around that. But if you know that's happening, then you know they've got a money issue and maybe not prescribing them the most expensive prescription that may be the best one that they could use for their disease process, but you would at least know that there's a problem.
Amanda, that's wonderful. And also Allison from Caldwell has some good insight as well. So that's great, Amanda. Allison saying what we have done is implemented community health workers, and we are trying to help them find those resources. It's a new program, but it's been amazing so far how much is out there. Allison, I'm already seeing a future little mini presentation from you about what you are seeing. Anything that you want to come off mute and
What
say
I
about the
would
program?
say too is I think even gathering the information is you don't know, like last year, UDS, you get a snippet of homeless. Well, we only had 64 people last year, but this year we have 245 homeless. So when you ask these questions, that kind of gives leadership, you can start trending this and then look for grant and, it kind of helps with needs and you can go off after funds to get the support that you need to help the people, because people can't get healthier if they're worried about food or don't have anywhere to sleep. They can't refrigerate their insulin or whatnot. It's really critical. So
it could also help determine the programs that you need. So if you're seeing that you have a lot of patients that are asking for this service and having these problems and you don't have that service, maybe that's the call for action. with your center.
I should mention too, Amanda, you brought up, there's probably somebody in the community around you who could meet a particular need, even if your center isn't prepared for that. Underneath the wheel, the social determinants of health wheel, is a built-in community resource directory. If I click on this link, it will automatically filter for services that meet the needs where the domains where my particular patient was assessed to have risk. If I select one of these, not every center has submitted resources for the directory, but you can see we have quite a few in here. And I've removed my patient's address now just to give you a sense of kind of some of the types of resources that we have in here. But they will naturally filter down to either the patient's location, resources that are closest to the patient's home address, or if the patient doesn't have a home address, closest to the clinic, the address for the clinic where you're logged in. So some of these are educational, like the American Heart Association. Others are food banks, places that patients can go for material support. We'll look in some of the financial assistance categories. We have tax preparation services that are free that could be helpful to patients. We have law and citizenship and immigration support. I mean, there's a wide variety of resources that can be imported here. So if you, the centers that have submitted resources to have in the directory, they're there available for your use, and others can benefit from those as well if you're in a same geographical location. If you have not yet submitted resources and you're interested in using this type of directory to help meet patients' needs, social determinant needs, using external community resources, please submit a list to the Healthy Planet team. We can send you, before you submit the request, we can send you the template of the formatting that we need to be able to collect the data to import those resources for you. And then you'll be able to draw right from this directory. And when you select these, I'll select a few. These go on the after visit summary automatically for a scheduled visit. They can also be sent to a patient, a MyChart patient, through a MyChart message. You can also text or email them to patients directly. So there are a lot of methods to getting these resources, getting patients connected with these resources.
Hey, it's Cassie. I want to add in here. I saw a comment in the chat about HCN is looking at integrating with Unite Us. I just want to call out a couple of differences. This that Dawn is displaying, we have built into Epic. So you're going to be able to send it through the AVS. You're going to be able to send it to the patient through MyChart. You're going to be able to send it through the patient through other secure communication pathways. The Unite Us platform exists outside of Epic. So basically we would be putting with the PDMP, we would be launching an external website, and you would have to place another referral in the Unite Us system to send information to the Unite Us community members that are on that platform. Anything that they do in closing referral loops or with the addressing of care gaps stays in Unite Us. It doesn't necessarily come back into Epic. There are definitely different types of integration methods. They've advertised a FHIR integration, which is basically Epic using FHIR to send them demographic data. But information coming from Unite Us back into Epic is still in development. So I just want us to be aware of the limitations and the expectations as you use third-party vendors to connect you with community resources. It's an amazing service, an amazing way for community members to connect. However, you may have a couple of follow-up steps that you have to do in Epic in order to actually close the loop or close the social risk factor for the documentation in Epic. Otherwise, it's going to look like it's always open. So just want to make that clarification here as we work to give you the Unite Us portal within Epic.
Wonderful, Cassie. Thank you so much. I just want to bring up a few other things in the chat because the chat is very exciting as well. So one question was, can we have the expert on the screening tab without having to go to the flow sheet? And Cassie's response is, it depends how long the screening form is. Once a flow sheet gets to a certain number of rows, the navigators can't display it, and it flips you to flow sheets. but we can discuss how to
Yeah.
shorten it.
Yeah, I think that with Espert, there's like different screeners, right? And the way that it's built now is it's built into a giant biopsychosocial workflow. So if we can agree on the screeners that should have like are individual for Espert, and we can pull them out to be shorter screening questionnaires, then yes, we can make them their own flow sheet or navigator section. But when I think of Espert, the way we have it built now, it's built into another larger template to address other items.
Great. And thank you, Stephanie Smith, for saying that in the chat, HCN has a best practice advisory, a BPA work group, where we're working through these active best practices in EPIC and optimizing them. The work is being done with our EPIC physician champion, so we'll take a look at this one for Espert. Wonderful. Portia, just wanted to bring up your questions were excellent, and they are the questions that we all have. So keep bringing up those types of questions. This is just one of many webinars that we'll have about SDOH. The one thing you mentioned, Portia, about health equity is really one of the root causes of health equity too is social determinants of health and how to combat those. So when you think about what you're doing around health equity, when you're looking at it for Healthy People 2030, SDOH is really embedded in that too. So I think there's a big story we can tell around how we're addressing SDOH as it relates to health equity. I think Hawaii mentioned HICHC has a dedicated staff to address SDOH assistance. They use health equity patient navigators. And Hawaii also uses Unite Us to refer to community resources. So that's great. All right, back to you, Dawn.
Sure. There were just a few other things that I wanted to touch on. We won't spend too much time on them, but one is if I press the F1 key on my keyboard in Epic, oh, you know what? I think my Teams won't let me use F1.
For learning fun?
Usually, yeah, F1 for learning fun. So there is, when I'm pressing F1 here on my keyboard, it's just launching some funky thing in Teams, which is not helpful. But it will typically launch your Learning Home dashboard, which is where we store all of your tip sheets and guides and everything in Epic. There is an SDOH reference guide in that dashboard that will go into all the details of the SDOH workflow that we've walked through, the exact questions in the prepare that map to each section of the wheel. It goes into the alternate screeners that are available. It goes in enough depth to get to the LOINC mappings and it goes into a lot of good detail for this whole social determinant workflow in EPIC and how we've configured it. So I encourage you to use that if you have questions following the demo about how to use these tools.
And if we go back to the PowerPoint, there's a screenshot of it too, a screenshot of the program guide.
Sure. Could we do that at the end? I did have just a couple other quick things that I wanted to show in Epic before we jump back to the slides. Great.
Yep.
Thank you. I did want to give you a sneak peek. There is, let me see if the nurse has access. If not, I will find another user to show you. I'm logged into an upgrade environment. We have an Epic upgrade coming in May of this year. It's a pretty big one. And with that upgrade, we have a new SDOH operational dashboard that it will only start collecting data upon upgrade. It's going to start in May when we upgrade. So what you're seeing here is the jump that's in each of these is it started when we upgraded this particular environment, and now it's collecting data going forward. But it's going to show overall SDOH screening rates and overall positivity rates, and then breaks it down by domain. You can see all the adult, child, adolescent domains all the way down here. You can limit which domains you want to see. So if you operationally are focusing on just food and transportation and housing, you could limit it to those three as an example, and it will filter it down for you. You can also summarize at the registry level. So like patients who are on a particular registry, maybe you want to focus on patients with diabetes or hypertension, or focus on a registry. You can also do it by service area or even an individual department. Maybe your community outreach department, you want to see how their screening rates are looking. So this is going to be a really cool tool that's coming that will just support your overall screening operations and will give you better insight into what's going on and what the positivity rates look like. So be on the lookout for that. I think those were the things. Cassie, was there anything else you wanted to show it,
yes.
wanted to throw in? Go for it.
Yes, can you pull up Donatron, the patient, because there's one other fun sneak peek. You guys are doing so much with care coordination and your programmatic episodic monitoring. Another new sneak peek is in the storyboard. They have added visibility to all the hard work that you do, that you can show every provider what you're doing, how you're working on, and what social determinants of health you are addressing. We are so excited about these enhancements.
Thanks, Cassie. I'd forgotten, and that's like one of the best parts of this upgrade.
See, guys, this is why we get on QTECH calls. This is awesome.
So excited.
All
well,
right,
you heard it here,
Karen.
folks, everybody. QTECH. QTECH calls. All right. We'll go back to the slide set if we can.
Sure.
Fantastic job, Dawn. Thank you so much for this. And everybody, this is just the start of our discussion around SDOH, because it's one of the pillars of Healthy People 2030. So there's a lot coming up. And I'll have Dawn give some more info about the program guide.
Sure. Yeah, this is just an image of what the program, the SDOH reference guide looks like, the one I was mentioning on your Learning Home dashboard. We update it regularly as we make updates, if we link new screeners, if we do new mapping, if we, add something to the workflow. So you'll always have the most recent version on your Learning Home dashboard. If you go to the next slide, this is where you can find it. It's under the Healthy Planet section after pressing F1 to launch your Learning Home dashboard. And I think we have one more. Oh, and then that's you, Karen.
Yeah, great. Thanks, Dawn. So yes, F1 for Learning Fun. The Healthy Planet team took an amazing amount of time on that guide. Please pull it up. Lastly, and I'll turn it over to Natalie for announcements. I'm taking this from Jillian at Value Based Services. We screen, we intervene, and we code. So we've covered a number of things in these QTECH meetings around SDOH. In the future, we want to talk about the roles that are specific to SDOH. You covered that today, everybody. Use of my chart, continued output for the dashboards, how we're intervening. We started talking about that today, but we'll have that in the future. And then we'll talk about Z codes and future tools. And with that, I'll pass it over to Natalie to talk through some closing remarks.
Thank you, Karen. And thank you, John and Cassie and Stephanie Smith, for your expertise on this subject matter. Just some closing remarks as we wrap up today's meeting. So we wanted to remind you of our upcoming pharmacy symposium in March. So if you are interested, or if you have pharmacy staff at your health center interested in participating, we do have a few in-person spots available, as well as virtual opportunity as well. So we encourage you to take part in that. We are excited to announce our next Spring Clinical Leaders Workshop will be May 20th through the 22nd. It will be in Chicago at the Alliance Chicago headquarters. This is the save the date. The registration will be open soon, and it will be in-person attendance only. So we will have more information on that, and registration will be open soon. We also are happy to announce our 30th annual board educational conference in June. So as many of you may be aware, as QTECH members, we reimburse for one health center member to attend the conference. We reimburse for registration fee and 3 nights hotel stay. The only stipulation or requirement is for that selected person to participate in our QTECH health education track. So we'll have more information on that. Please feel free to scan the QR code there as well. It's taking place June 20th through the 22nd. It's a big one. It's our 30th anniversary, so we look forward to seeing you all there. And lastly, we will have our next meeting on Wednesday, March 28th. We're hoping to do all things UDS, lessons learned. We have a lot of nice updates for you all for that meeting, so we hope to see you all in March. And thank you again to all our speakers, Michelle, Stephanie, Cassie, Dawn, Karen, everyone for their expertise and their time today. So thank you so much. We will send out the recording and slides after the meeting, and we look forward to seeing you in March. Thank you all so much.
Thanks, everyone. Have a
This
great
is
day.
great. Thanks, everyone. Bye.
Thank you. Bye.